Good evening, everyone, and thank you so much for being here with me today, whether you're watching this from your living room, your kitchen table, or maybe even your doctor's waiting room on your phone. I want to start with a question, and I want you to really think about it before you answer. How many of you know the name of the blood pressure medication you take every single morning, but have absolutely no idea why your doctor chose that particular pill for you instead of one of the dozen other options sitting on the pharmacy shelf? If you're being honest with yourself, and I see a lot of nodding heads out there, the answer for most of you is that you simply take what you're told to take. You swallow it with your morning coffee or your breakfast, and you trust that the person in the white coat knew what they were doing. And look, that trust is not misplaced. But today I want to change something for you. I want to pull back the curtain a little bit and walk you through exactly what is happening inside your body when you take Lisinopril or Losartan or Amlodipine, because these three medications are, without question, the three most commonly prescribed blood pressure medications for people over the age of 60 in this country and in many countries around the world. And yet, in my 30-plus years of practicing medicine, I have met maybe one patient in 100 who could tell me the actual difference between these three drugs. Not because patients aren't smart. Please don't ever think that. It's because we, as a medical profession, often move too fast. We write the prescription, we say, take this once a day, and we move on to the next patient because there's a waiting room full of people and only so many hours in the day. But you deserve better than that. Your parents deserve better than that. Your grandparents deserve better than that. And so tonight, I am going to slow down, and I am going to talk to you the way I wish every doctor talked to every patient, like a real person in real language, without the jargon, without the rush, and without pretending that this is simple when honestly, it isn't always simple. Let me tell you a quick story first, because I think it'll set the stage for everything we're about to discuss. Years ago, I had a patient, a wonderful woman in her late 70s, sharp as a tack, used to be a schoolteacher, and she came into my office absolutely furious with me. Not because I had done anything wrong medically, but because she had switched from one blood pressure medication to another and nobody had explained to her why. She had been on Amlodipine for years. Her ankles had started swelling up like balloons. She went to see a different doctor while I was away, and that doctor switched her to Losartan without a word of explanation. She thought something terrible was wrong with her. She thought maybe her kidneys were failing. Maybe her heart was giving out, and she spent 2 weeks in genuine fear before she came to see me. And when I explained to her that the swelling in her ankles was a very common, very well-known side effect of the type of medication she was on, called a calcium channel blocker, and that switching to an ARB, an angiotensin receptor blocker, was simply a different way of achieving the same goal without that particular side effect, she nearly cried with relief. She told me, "Doctor, if someone had just explained this to me in plain English from the very beginning, I would have saved myself 2 weeks of terror." That story has stayed with me for years, and it's a big part of why I wanted to give this talk today. Because fear of the unknown is so much worse than understanding, even when the understanding involves some scary-sounding words. So let's get into it. Let's talk about blood pressure itself for just a moment, because you can't understand the medications until you understand what they're actually fighting against. Blood pressure, in the simplest terms, is the force of your blood pushing against the walls of your arteries as your heart pumps it around your body. Think of your arteries like garden hoses. When you're young, those hoses are flexible, elastic, they can expand and contract easily as water flows through them. As we age, and this happens to every single one of us whether we like it or not, those arterial walls become stiffer, less flexible, sometimes narrower due to plaque buildup. And when that happens, the same amount of blood flowing through a stiffer, narrower tube creates more pressure. That's high blood pressure, or hypertension, in its most basic form. Now here's the part that I really need you to sit with for a moment, because it's the reason we're all here tonight talking about this. High blood pressure, left uncontrolled, is often called the silent killer. And that phrase is not dramatic exaggeration, it is clinical fact. It doesn't hurt. It doesn't announce itself with symptoms most of the time. You can have a blood pressure of 170/100 and feel completely fine, go about your day, mow your lawn, play with your grandchildren, and have absolutely no idea that inside your body, that pressure is quietly damaging the delicate lining of your blood vessels, forcing your heart to work harder than it should have to, straining your kidneys, and dramatically increasing your risk of stroke, heart attack, heart failure, and kidney disease. For seniors specifically, uncontrolled high blood pressure is one of the single biggest modifiable risk factors for stroke and stroke. As many of you know from watching it happen to a parent, a spouse, a friend, can steal away independence in an instant. This is why we treat it so aggressively. This is why your doctor keeps checking your blood pressure at every single visit and adjusting your medications. It's not busy work. It's genuinely one of the most important things we do to protect your future. Now, with that foundation laid, let's talk about our three main characters tonight: Lisinopril, Losartan, and Amlodipine. I like to think of these three medications as three different tools in a toolbox, each one built to solve the same fundamental problem, which is lowering your blood pressure, but each one going about it through a completely different mechanical pathway inside your body. Understanding that different pathway is the key to understanding why your doctor might choose one over another for you specifically, and why what works beautifully for your neighbor might not be the right fit for you. Let's start with Lisinopril. Lisinopril belongs to a class of medications called AC inhibitors, which stands for angiotensin-converting enzyme inhibitors. I know, that's a mouthful, so let me break it down in a way that actually makes sense. Inside your body, there is a hormone system called the renin-angiotensin-aldosterone system. Think of it as one of your body's natural blood pressure-raising systems. It exists for good reason, evolutionarily speaking. If you were bleeding, if you were dehydrated, this system would kick in to constrict your blood vessels and retain fluid to keep your blood pressure up and keep you alive. But in modern life, with high-salt diets, sedentary lifestyles, and aging arteries, this system often becomes overactive and works against us instead of for us. Lisinopril works by blocking the enzyme that converts a substance called angiotensin 1 into angiotensin 2. Angiotensin 2 is a very potent vessel constrictor. It's like a hand squeezing a hose tighter. By blocking that conversion, Lisinopril prevents that squeezing from happening as intensely, and your blood vessels stay more relaxed and open, which lowers your blood pressure. But Lisinopril does something else too. Something that makes it particularly valuable for certain patients. And this is really important for those of you who have diabetes or early kidney disease. ACE inhibitors like Lisinopril have a protective effect on the kidneys themselves, particularly on the tiny filtering units inside the kidney called nephrons. For patients with diabetes, where the kidneys are already under stress from years of blood sugar fluctuation, Lisinopril isn't just lowering blood pressure. It's actively protecting kidney function over the long term. This is why so many of my diabetic patients are on an ACE inhibitor, even if their blood pressure is only mildly elevated, because we're using it as much for kidney protection as for blood pressure control. Now, Lisinopril is not without its quirks, and I want to talk about them honestly because I think patients deserve honesty, not a sanitized version of events. The most famous side effect of Lisinopril, and really of the entire ACE inhibitor class, is a dry, persistent, tickly cough. This happens because when you block that converting enzyme, a substance called bradykinin builds up in the body, and bradykinin can irritate the lining of the airways in some people. This cough affects somewhere between 10 and 20% of people on ACE inhibitors, and it usually shows up within the first few weeks of starting the medication, though I've had patients develop it after months of taking the drug without issue. Now here's what I want every senior watching this to understand clearly. If you develop a persistent cough after starting Lisinopril, please do not just assume you're getting a cold, or that it's allergies, or that it's nothing. Please call your doctor. It's an easy fix. We simply switch you to a different medication, often to an ARB like Losartan, which we'll talk about in a moment, and that cough almost always resolves completely within a few days to a couple weeks. The second thing I want you to know about Lisinopril, and this one is more serious, is a rare but potentially dangerous side effect called angioedema, which is swelling, usually of the lips, tongue, throat, or face. This is rare, but it can be life-threatening if the swelling affects the airway, and it can happen even after years of taking the medication without any problem, which is genuinely one of the strange and frustrating things about this particular side effect. If you ever notice sudden swelling of your face, lips, or tongue, or difficulty breathing or swallowing while on Lisinopril, that is an emergency room visit, not a wait-and-see situation. The third thing seniors specifically need to watch for with Lisinopril is its effect on potassium levels and kidney function, especially in the first few weeks after starting or after any dose increase. Your doctor should be checking your blood work, specifically your kidney function tests and your potassium level, about 1 to 2 weeks after you start this medication or increase the dose, because in some people, particularly those with underlying kidney disease or those who are also taking potassium-sparing diuretics or certain other medications, Lisinopril can cause potassium to rise to dangerous levels or can cause a temporary dip in kidney function. This is manageable, this is watchable, but it requires that follow-up blood work, and I cannot stress enough how important it is that you actually go get those labs done when your doctor orders them, even if you feel perfectly fine. Feeling fine and having normal lab values are not always the same thing, especially with this class of medication. Now let's move to Losartan, because Losartan and Lisinopril are frequently confused by patients, and I understand why, because they're going after very similar targets in the body, but through a different door, so to speak. Losartan belongs to a class called ARBs, angiotensin receptor blockers. Remember that angiotensin II I mentioned, the potent vessel constrictor. Well, instead of preventing its production like Lisinopril does, Losartan works further downstream. It blocks angiotensin II from actually attaching to its receptors on the blood vessel walls. Think of it this way. If Lisinopril is stopping the factory from producing a chemical, Losartan is letting the factory produce that chemical just fine, but putting a lock on the door so that chemical can never get inside to do its damage. The end result, blood vessel relaxation and lower blood pressure, is very similar between the two drugs, and honestly, for most patients, Lisinopril and Losartan are considered roughly equivalent in terms of how effectively they lower blood pressure and how well they protect the kidneys in diabetic patients. So why would a doctor choose one over the other? This is where it gets personal, and this is exactly the kind of conversation I wish more doctors had with their patients. The single biggest reason we switch someone from Lisinopril to Losartan, or start someone on Losartan from the very beginning, is that dry cough I mentioned earlier. Because Losartan works downstream of the bradykinin buildup process, it essentially never causes that cough. If you are a senior who has tried an ACE inhibitor in the past and developed that annoying, persistent cough that kept you up at night or embarrassed you in public, Losartan or another ARB is almost always the next logical step, and the vast majority of patients tolerate it beautifully with no cough at all. The angioedema risk I mentioned with Lisinopril is also significantly lower with Losartan, though I want to be honest with you, it is not zero. It's rare enough that we still consider ARBs generally safe even in patients who've had a mild reaction to an ACE inhibitor, but your doctor will still want to monitor you, especially in the first few weeks. Losartan has its own set of things to watch for as well. Just like Lisinopril, it can affect potassium levels and kidney function, so that same blood work monitoring schedule applies, especially after starting the medication or increasing the dose. Losartan can also cause dizziness, particularly when you first start taking it or when your dose is increased, and this brings me to something that I think is absolutely critical for every senior in this audience to hear, and I'm going to pause on this point because it matters so much. Dizziness and lightheadedness, especially when standing up quickly from sitting or lying down, is one of the most dangerous side effects of blood pressure medications in older adults, not because the dizziness itself is dangerous, but because of what it leads to, which is falls. Falls in seniors are not a minor inconvenience. A fall that results in a hip fracture can be the beginning of a cascade that leads to loss of independence, nursing home placement, and in some tragic cases, death within a year of the fracture due to complications. This is not me trying to scare you. This is decades of medical literature and decades of my own clinical experience talking. So if you are